Pelasan silanganan, hanap ng puso, sa dibdib mo'y buhay. Lupang hinirang, duyan ka ng magiting, sa manluluti, di ka pasisiil. Sa dagat at bundok, sa simoy at sa langit mong buhaw, may dalagang tula at awit sa paglayang minamahal. Ang kisap ng wataw at lu'y tagumpay na nagniningning, ang bituin at araw niya kailan pa may di magniningning. Lupa ng araw na luwalhatin puta, langit sa piling ko. Aming ligaya na pag may mga atin na pumatay ng dahil sa'yo.
Bago pa man magsimulang tumigil ang mundo nang dahil sa pandemya, napakadami na namin ginaharap.
is your doctor. She is a phone call away. Whenever, wherever you need her. If there's anything you need to know, she will be in touch. Anytime, day or night, even on holiday. She doesn't just have one solution, but the one you need. Medgate. Call Doc. Anywhere, anytime, no line.
This is our home. And we're doing our best to keep it safe and free from harmful elements. So how do we ensure that your next visit here will be truly safe and memorable? Simple. We went back to our roots to find out what makes Okada Manila special. Okada Manila is grounded on Magokoro, or a true heart that's dedicated to service. Fusing the finest of Filipino and Japanese hospitality, we have built a world-renowned destination. Now, our core principle is put to action as we adopt a comprehensive system designed to keep you safe and healthy. We call it 3T, which stands for True Clean, True Safe, True Heart. With True Clean, we use the leading edge in technology to sanitize critical areas, from UV robots to walk-through disinfection tunnels. We have even innovated in how well we sanitize the smallest spaces. With True Safe, you can be sure you are in good hands. Our people have undergone stringent training to adapt to the demands of the new normal, to think steps ahead, to respond to your needs before you realize it. While True Heart is the wellspring of these measures, it has allowed us to ensure that every act of service is done with commitment and grace, as well as inspiring us to develop innovations to further enhance safety, such as hygienic cashless transactions using Okada Pay. Indeed, every space in the property is enhanced with a gold standard in cleanliness and safety. The 3T system prioritizes your well-being, giving you unparalleled peace of mind. So that when we welcome you back, you'll find a sanctuary that is truly clean, where you'll feel truly safe, delighting you with service with a true heart. Always driven by our values, we know only of one thing: to give you a place that even in these challenging times, you can call your home.
Good morning. I am Dante Klinkang, the Chairman and CEO of the Manila Times. Welcome to the Manila Times Business Forum, a good job for Philippine healthcare. Our topic today has been in the news for 2 years now, and yet we are still talking about it today. Of course, the reason for that is that the pandemic is lingering. Late last year, when we thought that it was all over, we saw Omicron. And now that Omicron itself is receding, we see that cases are spiking or starting to spike elsewhere, including Hong Kong. So we are still eager to hear the latest about the pandemic, even as the country transitions from a pandemic to endemic. First, let me greet our speakers this morning, the Honorable Maria Rosario Singvergere, the Undersecretary of the Department of Health. We also have Mr. Carlos de Silva of Insular Life and Dr. Shirley Domingo of PhilHealth. I'd like to thank our partners and sponsors who made this event possible this morning. First, our special partners, Consumer Protect, Medgate Philippines, General Life Assurance Philippines Incorporated, and Okada Manila. Thank you to our sponsor, International SOS, Also to our organizational partners, the Management Association of the Philippines, or MAP, the Financial Executives Institute of the Philippines, or FINEX, the Davao Chamber of Commerce and Industry, the British Chamber of Commerce in the Philippines, French Chamber of Commerce and Industry in the Philippines, the Italian Chamber of Commerce in the Philippines, and of course our media partner, the Manila Times TV. I'm also swapping out my usual partner for this forum for a local choice, Red Mendoza, who usually covers our health stories. So we should begin. We do have some rearrangement in our order of speakers today. Red, can you please introduce our first speaker, Mr. De Silva?
Yes, thank you very much, Sir Klink, and good morning to everyone. Now, I am going to introduce to you our first speaker. Mr. Carlos Da Silva was for many years as a senior executive of the Insular Life Assurance Company Limited. He has extensive experience in marketing and sales and has held several key positions in the company for many years. At some point in his career, he was president for several years of the Payroll Deduction Insurance Association Incorporated, or the official trade organization of life insurance companies doing business in the Department of Education, Culture, and Sports payroll deduction market. His expertise likewise includes organizing and managing projects, agency training and development, and formulating and implementing strategic business plans. During his career at Insular Life, he was seconded to one of its wholly owned subsidiaries, the Insular Life Healthcare Incorporated, as Senior Vice President and Head of Sales and Marketing Division, and was later promoted to President and Chief Operating Officer until his early retirement in April of 2009. Concurrent to his position at Insular Life Healthcare, he was the President of the Association of Health Maintenance Organizations of the Philippines Incorporated, the first insurance commission-recognized trade organization of HMOs, or health maintenance organizations, in the country. To date, he is the association's corporate secretary and executive director, and he has been with the HMO industry for over 2 decades and counting. In late last year, he was adjudged as the Association Executive of the Year 2021 in the AMSUSI, or Association Nurture Growth Through Social Unity and Sustainability Innovation Awards of the Philippine Council of Associations and Association Executives, or PICAE. He has a Bachelor of Science in Commerce from the Jose Rizal College and is an alumnus of the Asian Institute of Management, where he took his business management program, managerial process and practice course, and the AIM top management program. Friends, ladies and gentlemen, let me introduce to you the Executive Director of the Association of Health Maintenance Organization of the Philippines Incorporated, Mr. Carlos Da Silva.
Okay, thanks, Red. Let me just get this adjusted. Hold on, what happened to my... Can you remove the screen first, please, Red? Okay, can you bring it back, please? Are we on?
Yes, sir, we are.
We are, okay. Magandang araw sa inyong lahat. On behalf of the AMOP, thank you for your invite and the opportunity to share with all your viewers how the HMO industry continues to be an integral part of the country's health delivery systems for the past 4 decades and counting. And more so under a COVID-19 environment, in tandem with the Department of Health, the PhilHealth, and the Insurance Commission. To discuss the HMO industry would take hours on end, and yet we'd only be scratching its surface. Hence, with only 15 minutes to get my message across, let me cut to the chase and pick out what I believe are key points to make during this very brief rollout. Next slide, please. Allow me to begin by mentioning very briefly what our organization, the Association of Health Maintenance Organizations of the Philippines, Inc., or AMOPI, is the first Insurance Commission recognized trade organization of HMOs in the country. It has been in existence for the past 35 years and counting. It is and has always been composed of industry leaders. Then, some 40 years ago, and more so to date. Next slide, please. Just like any other business, managed care, let me repeat that, managed care of the HMOs included, the interest of all stakeholders must be safeguarded at all times. The American Managed Care and Review Association defines managed care as a comprehensive approach to healthcare delivery that encompasses planning, education, monitoring, coordinating and controlling quality, access, and cost, considering the interests of patients, providers, and payers. Next slide, please. Under an HMO setting, the spirit of bayanihan is well ingrained and established. Said in another way, and coming from health economics and actuarial perspectives, the healthy subsidizes the not so healthy and or the sickly. From the perspective of health economics, if healthy people just pay a little bit more for their health care, cost for the entire system decreases because the sick, generally older and perhaps financially challenged, may find it hard to pay for healthcare services. Now, from an actuarial perspective, it is expected that a younger, stronger, and a healthier individual will incur less health care expenses than an older and perhaps sickly individual. And therefore, what could possibly be saved in terms of program utilization of the former could be effectively used for the latter. Under an HMO setting, plan holders are covered up to the plan's maximum benefit limit per illness or injury per year, or aggregate benefit limit per year. The same ranging from 50,000 for wardroom accommodation to about 1 million to 1.5 million for private and suite room accommodations respectively. Now you'd ask us, what would be the maximum benefit limit perhaps of a semi-private? That would range something from 75,000 to 100,000 at today's rates. Next slide, please. Let me now go to my fifth point that I'd like to make. HMO coverages include in- and outpatient benefits, wellness care, emergency care, dread disease care, of course, latest modalities of treatment, and a host of benefits like optional benefits like maternity, dental, prescription meds, life insurance, etc., etc. These are optional benefits that you can purchase and pay a separate price for them on top of the mother policy, the HMO mother policy that one gets, either as an individual or either as part of a corporate account made up of the employees and their qualified dependents. Next slide, please. Under an HMO setting, I'd like to make the point that no hospital deposits are required from the patients outside of the latter's MBL or maximum benefit limit or ABL, aggregate benefit limit, as indicated in the HMO's letter of authority. So when a plan holder goes to the hospital and is supposed to be confined, they would contact the HMOs and the HMOs would send a letter of authority indicating the patient's MBL or ABL, what is remaining of it at that point. The second point I'd like to make, under an HMO setting, there is no balance billing of patients except for voluntary room upgrades when a patient would want, outside of the room accommodation that he purchased, let's say he purchased a semi-private, but for some reason he would like to be upgraded to a suite or a private room accommodation, then there is balance billing. Outside of that, there is no balance billing for patients except for voluntary room upgrades, non-coverable health conditions, and when a member exceeds his or her maximum benefit limit or aggregate benefit limit, in which case the attending physicians may bill the patients either based on the HMO's PF rates or based on the memorandum of agreement rates if the doctors are into the association's 4 MOA initiatives, specifically with the Philippine College of Surgeons, the Philippine College of Physicians, the Philippine Obstetrical and Gynecological Society, and the Philippine Pediatric Society. The third point I'd like to make under an HMO setting is, in availing of benefits, patients are required to use their HMO's affiliated institutional healthcare providers and accredited doctors nationwide. Why is this so? Because if you go to a non-accredited facility, there is no credit line of the HMO. Although we are practically all over in all hospitals of the land, if by chance the hospital is non-accredited and you go to that hospital, then there is no credit line of the HMOs, and therefore the patient may have to pay out of pocket following the HMO's rules and have these out of pocket payments reimbursed with the HMOs. Now, when you have to go to the hospital for outpatient or inpatient services, entry point for non-emergency cases, let me repeat that. Entry point for non-emergency cases is the HMO's medical coordinators in their hospitals of choice, who would refer them to their network doctors in all fields of specialization. Let's now go to the next slide, please. Item 7 I'd like to emphasize would be the important information of the HMO industry. At this point, I'd like to share this with you that currently the HMO industry has 30 SEC registered, IC licensed HMOs in the country. 30 na yan. I hope it could grow further than that. But early in the industry, some 40 years ago, it was started by only 6. And these are the initial members of the AMOP. Now, second point, about 95% to 100% of an HMO's corporate portfolios are for corporate accounts. whose plans are PhilHealth integrated. PhilHealth integrated, meaning the first peso comes from PhilHealth in benefits payments. Not very many HMOs in the country have individual plans for some reason. Most of them concentrate on corporate accounts, having corporate plans only. Now, corporate accounts have employees. Employees are PhilHealth members, and the employers pay 50% of an employee's PhilHealth membership premiums. Am I right? And they normally, when they are going to provide their employees with an HMO coverage as part of their employee benefits program, they normally demand a PhilHealth integrated HMO plan whose membership fees are significantly discounted because it is PhilHealth integrated. So the HMOs are going to discount the membership fees for a PhilHealth integrated plan, and that's where the benefit comes in terms of the payer, the corporate client. Now, you ask me, what is the benefit of the employee since he also pays at least 50% of the PhilHealth premiums? He simply gets an HMO coverage which definitely complements and supplements the PhilHealth benefits that he has. And most employers would not bill the employees for their PhilHealth coverages. Now, to be transparent about it, some corporate accounts could ask the employees to share a percentage, especially for their dependents, qualified dependents. But more often than not, employers who buy HMO coverages for their employees would give it to the employees as an employee benefits program, free of charge. The last point I'd like to make, 7.3, is the industry has about 7.5 million plan holders nationwide, and this I believe is increasing year after year. We started with a smaller amount, but all told in the entire country nationwide there must be 7.5 million plan holders today. Now, you would ask me, being in the HMO industry, why is there an estimate? Simply because there are life insurance companies in the country that have genuine HMO products in the marketplace, or HMO-like products in the HMOs. And I believe that they classify these HMO members as life insurance because they are a life insurance company. So it is really very difficult for the HMO industry per se to really get a complete reading on the total number of HMO plan holders in the country. The 7.5 comes from the industry leader, which is the association, the AMOP. There is another association, okay, that was recently organized some 2-3 years ago, which we communicate for matters of this nature. So between our figures and we extrapolate what the life insurance companies could have, we come up with an expected and estimated 7.5 million plan holders nationwide and counting. Next slide, please. The AMOP is affiliated with about 1,000 institutional healthcare providers nationwide and about 60,000 accredited doctors likewise nationwide. Am I being heard? I'm sorry, I just want to check that out.
We can hear you, Mr. De Silva.
Okay, thank you very much. Thank you very much. I don't have it in the screen. I'm talking blankly in the screen, okay? So thank you very much for that confirmation. The next point I'd like to make is about 60% to 70% of a private hospital's business portfolio are HMO business, 60 to 70. It started with a lower percentage, 20, 30. Throughout the years, it has caught up, it has increased, simply because the demand was tremendous, especially for the doctors of the hospitals. Okay, now let me go to the next slide, please. The sixth point I'd like to make, HMO payments to some of our smaller, smaller affiliated hospitals range from a couple of thousands of pesos to $1 million, or about 3 million to about 10 million, to over 100 million annually. Over 100 million annually. These are hospitals in Batangas, in Lipa City, up north, down south, the bigger ones. The smaller ones, easy, would be 100 million, 3 million to 10 million annually. Now, for the bigger hospitals, especially in Metro Manila, these come up to about 1.5 to 2 billion a year. Clearly, all private hospitals need HMO businesses. While the HMOs likewise need the hospitals and our accredited doctors, losing one hospital, or 3, or even 10, and even the bigger ones, will not result to an HMOs not being able to maintain its market reach and market share. 7.7 point. Most HMOs, through their 2 major IC recognized trade organizations, remember earlier I did say we are in existence for the past 35 years, and some 4 or 5 years ago, a new organization was organized. This is the PAMOC, the Philippine Association of HMO Companies Incorporated. It's called PAMOC. Now, both of us have existing MOAs with major medical and surgical specialty societies, with the Philippine College of Surgeons, the Philippine College of Physicians, the Philippine Obstetrical and Gynecological Society, and the Philippine Pediatric Society, and provide MOA participating doctors with enhanced terms of engagements, professional fees included. You see, the way it's done is every HMO can negotiate with any doctor of the land. And if the doctor signs on the dotted line, the professional fees negotiated by that particular HMO forms part of the service agreement the HMO has with its servicing doctor. However, if these doctors belong to the PCS, PCP, the POGs, and the PPS, and perhaps the family doctors is an association we are now talking with because of universal health care, these doctors are now afforded enhanced terms of engagement, which include enhanced professional fees. So it's better for the doctors to join MOA initiatives. The next point I'd like to make is, under a COVID-19 environment, both the AMOP, and I said earlier, the PAMOC, provide since March 2020, when this really exploded, March 2020, enhanced COVID-19 PF rates. Because, our doctors are very important, and we know that they are exposed to SARS-CoV-2, and therefore, for face-to-face consults, we provided enhanced COVID-19 rates, which is 50% increase on top of the enhanced MOA rates, payable to MOA participating doctors. So they have been happy, we've been happy, we've been able to protect everybody in the industry. Next slide, please. Now, the 8th point I'd like to make is some of the more pressing issues we have in the insurance industry are the following. I've just narrowed down, there are a lot, but I have just narrowed them down to 2 things. Everybody knows of the spiraling medical costs everybody in the country is faced with. Now, particularly to the hospitals. almost all hospitals charge minimum high to extremely high facility fees, diagnostics, procedures, etc., including the controversial miscellaneous fees, which include, imagine this, which include nursing fees, cleaning and disinfection fees, PPEs is understandable, etc. Now, many times when I get this information, I call the hospital and I would ask them, in the past, prior to COVID-19, didn't the hospital clean the hospital premises? Didn't the hospital disinfect all the rooms in all its facilities? It did. And it incurred expenses for doing the same. However, under a COVID-19 environment, and I guess I would imagine it can be more extreme or heightened, they come up with miscellaneous fees, and we keep asking them, can you please give us a breakdown of these miscellaneous fees, because they can really be substantial. Okay? And the worst, there are some hospitals that would bill us 10,000 a day for nursing fees. I mean, when you go to the hospital, don't you expect nursing fees to be part and parcel of the service delivery of a hospital? The hospitals must have doctors, must have technicians, must have nursing in the first place. In every floor, you have a nursing station. And I would imagine nursing fees and all the salaries of the hospital personnel are already built in the cost of how the hospital markets its products and services to the general public. It's supposed to be built in. But on top of the cost of the room rates, there is a different nursing fee that is stacked in, and it really is very huge. I'm not saying all, but there are select hospitals, especially in the province, and we are negotiating that. Now, why are we doing this? Because if these nursing fees are run away, then it increases costs. And if it increases costs coming from an actuarial perspective, then this will have to be imputed. Ultimately, the buying public is going to be burdened by certain fees that shouldn't have been there in the first place. So I guess we're trying to encourage everybody concerned in the health delivery systems to examine the fees that come into play in pricing your products and services. Okay? Now, the next point I'd like to make is we are heavily taxed. Heavily taxed. In addition to the usual corporate tax at 25% of taxable income, I guess everybody knows that if you have a private corporation, you pay corporate tax at 25% of taxable income, and of course, various municipal taxes. HMOs are vatable. Repeat, we are vatable at 12% of gross membership revenues. Vatable at 12% gross membership revenues. Now, this situation has hampered HMOs to make healthcare costs more affordable for its clients, most of which are employers and their employees. And let me just talk very briefly. Remember earlier I did say that there are certain life insurance companies that have genuine HMO products in the marketplace, and that makes for an unlevel playing field because life insurance companies are VAT exempt. Repeat, the insurance code exempts VAT exempts life insurance companies from VAT. However, for the HMOs, we are vatable at 12% of gross membership fees. The life insurance companies pay only 2% premium tax, and therefore it becomes very difficult for an HMO to compete and makes for an unlevel playing field. I hope everybody realizes that. That is a problem that we have tried very hard to correct in our HMO bill, that we have tried to push in the PIFITA bill. If you are familiar with the PIFITA bill, later on I shall be discussing that more, but it has not been passed. I hope it is passed, but up up until it is passed, the unlevel playing field is still very, very felt in the marketplace. Item number 9. For the longest time, the HMO industry, particularly the AMOP, has been called upon to participate in public hearings of health bills and acts and the like, notably of late, and the DOH and Congress and the Senate and the Insurance Commission and PhilHealth can attest to this. One is the Universal Health Care Act and its IRR, including HMO complementation of PhilHealth benefits and initiatives. Remember, under the UHC, HMOs are being asked to complement and supplement PhilHealth benefits initiatives. Next slide, please. Stakeholders consultations for PhilHealth benefits, benefit development plans. So we have been in and out of consultations on stakeholders. The next one would be RA 10767, or the Comprehensive Tuberculosis Elimination Act and its IRR. Next slide, please. We have the RA 11166, or the Philippine HIV Policy Act and its IRR. Very briefly, what it says here that provided the PLHIV, meaning people living with HIV, comes to our doorstep and does not deny that they are a PLHIV, HMOs cannot deny accepting them, even if the application is highly anti-selective from an actuarial perspective. It's anti-selective. They come to us when they are sick already. However, the law is the law, and we are bound to follow the law. So there are certain underwriting processes that we have to put in place. Okay? Next slide, please. RA 1132, or the mandatory reporting of notifiable diseases and health events of public health concerns and its IRR. Example, HIV. Example, tuberculosis. Okay. Now, the next one would be, and I mentioned this earlier, the Passive Income and Financial Intermediary Taxation Act of 2019. This is the PIFITA bill, which still has to be passed today. Very briefly, what the bill is trying to do is they are trying to level the playing field by reducing everyone's the life insurance companies, the MBAs, and the HMOs, reducing the taxes to a uniform 2% premium tax. Now, if that is enacted, then it levels the playing field as far as the VAT is concerned. However, there are a lot of insurance commission repertorial requirements that make it very difficult for an HMO to comply with, and that anyone who sells a managed care product should be subject to, which includes life insurance companies. So the PIFITA is going to level the playing field to a great extent. However, for repertorials pertaining to HMO businesses, then anyone that sells managed care and services managed care should be subject to the same repertorial requirements of the Insurance Commission. Next, the Organ Donation Bill. Next, the Financial Consumer Protection Bill, among many others. Next slide, please. Now, for the longest time, we have provided several lawmakers with our draft HMO bill, which to date has not been passed. Years ago, and I remember one or two Congresses before, we came very close to having it passed, but unfortunately, it was not labeled a priority bill. And so, of course, we know that we have to start again. But right now is, in this Congress, we have given some congressmen and some senators a draft of the HMO bill, which I hope they are going to push and make it their priority bills. Now, it is imperative that an HMO law be enacted soonest. If the life insurance and non-life insurance companies have the insurance code, and the pre-need companies have the pre-need code, it's high time that the HMO industry has an HMO law as well. It is for the better protection of the Filipino buying public. To connect a title I put to my presentation this morning, which is HMOs in the country's health delivery systems, with that of the Manila Times, a good job for the Philippine healthcare, the word job obviously pertaining to COVID-19, I'd like to wrap up my talk with item 12 of my presentation. Next slide, please. Despite a lot of legal reasons, one of which is that epidemics and or pandemics are exclusions to an HMO's service agreement, a lot of HMOs covered SARS-CoV-2 since March 2020 to date for humanitarian reasons and on ex gratia basis. To date, the industry has covered thousands of COVID-19 patients and is glad to be of help to its valued clients, especially in these trying times. As most everyone would know, the HMO industry has been under an Insurance Commission regulatory environment since November 2019. Prior to that, and for the longest time, we've been under the Department of Health. I'm sorry, did I say 2019? It's 2015. Sorry, it's 2015. In November 2015, after nearly months on end of negotiating for the transfer of the HMO industry from the Department of Health to the Insurance Commission, in November 14 or 15, I think I remember, we were transferred to the Insurance Commission. Now, based on Insurance Commission statistics, repeat, these are statistics from the Insurance Commission coming from regular surveys amongst IC regulated entities, which are life and non-life insurance companies, mutual benefit associations and HMOs. COVID related insurance and medical claims paid in 2020 came up to 3.89 billion. And this is very important, with the HMOs shouldering 1.9 billion or nearly half of total claims paid. So nearly half or 1.9 billion comes from the insurance industry. Now, moving forward, from January to September last year, 2021, payouts by the HMO industry of 3.68 billion constitute 45% of the total COVID-19 claim payouts of life and non-life insurance companies, HMOs, and mutual benefit associations. 95%, 45%. Next slide, please. For the HMO industry, this brings us to a total 5.8 billion in COVID-19 payouts, covering the whole of 2020 and January to September 2021. It is almost sure this same trend is expected to be established for the last quarter of 2021, October, November, December 2021, and moving forward in 2022, and perhaps even beyond. Next slide, please. Allow me to end by reiterating that the HMO industry continues to make progress as they answer one of man's societal rights, the right to quality and affordable health care. The industry is glad to be an integral part of the country's health delivery systems and in helping the Filipino people live a healthier, more productive life. Next slide, please. Magandang araw at maraming salamat.
Thank you, Mr. De Silva. I hope you can stay around. We'll have a Q&A later on after Dr. Gigi. But for now, we have to bring on board our next speaker, who is, of course, at the front line of fighting COVID. So we need to slaughter in as soon as possible. So allow me to introduce our next speaker. Dr. Maria Rosario Singh-Vergere is the current Undersecretary for Public Health Services for the Public Health Services team and the official spokesperson of the department. She was previously the OIC USEC for Health Regulation for the Health Regulation team and Assistant Secretary in charge of the Public Health Services team. She also acted as OIC Deputy Director General, Field Regulatory Operations, Food and Drug Administration, Office Director of the Health Facilities and Services Regulatory Bureau, and Chief of the Health Research Division of the Health Policy Development and Planning Bureau. Undersecretary Vergere has committed decades to public service, having worked in Marikina City's health office before joining the Department of Health in 2007. Aside from public service, she is also committed to nurturing a soon-to-be public health leaders, serving as faculty of the Development Academy of the Philippines and part-time faculty in the Ateneo School of Government. She obtained her undergraduate degree in zoology from the University of Santo Tomas, her MD from De La Salle University College of Medicine, and her MPH from the University of the Philippines in Manila. Good morning, Yusek Vergere.
Yes, good morning, sir. At magandang umaga po sa inyong lahat. I'd just like to recognize, of course, Mr. Dante Ang, CEO and Chair of the Manila Times. Of course, my co-panelist, Mr. Carlos De Silva, sir, from AMHOPI, and also Dr. Shirley Domingo from the Philippine Health Insurance Corporation. And of course, we have our friend, our colleague from the media, Mr. Red Mendoza. So good morning po. On behalf of the Secretary of Health, Francisco T. Duque III, allow me to give our presentation for this forum. So next slide, please. So before we begin, let me just give everyone a brief overview of the current situation of COVID-19 in our country. So next slide. So we are seeing a continuous decline in cases of COVID-19 in our country. Based on this graph, the average cases this week have been reduced to an average of 1,972 cases per day, which is 44% lower than last week's average number of cases. Prior to the onset of transmission of the Omicron variant in our country, we saw a trend in the number of cases in the week of November 8 to 14 of 2021 with an average of 1,981 cases per day. So this was during the time that we were having the decline after the Delta situation. So next slide. The national admissions are also on a continuous decline with current admissions lower by 11,560 or 56%, and the total available beds are slightly lower by 411 from January 22, the peak of admissions. The total bed utilization is at low risk utilization at 23%. Meanwhile, the national ICU admissions are also on a decline, but at a slower rate than the total admissions. The ICU admissions have decreased by 829 or 42% of beds, and the available ICU beds remain slightly lower by 51 from our January 22 data. The ICU utilization rate remains to be at low risk at 30% utilization rate. Next slide. More than 62.5 million Filipinos are now fully vaccinated against COVID-19. As of February 20, about 134 million doses had been administered, 68.2 million received their first dose, while 62.5 million are fully vaccinated. On the other hand, about 9.7 million Filipinos have received their booster doses. Next slide. Since the Department of Health launched Bayanihan Bakunahan 3, we have inoculated 3.4 million Filipinos with their primary series and their booster shots. Among these accomplishments, over 2.3 million have received their primary dose and 1.09 million have received their booster shots. So we are thanking all of our volunteers and of course our healthcare workers during this Bayanihan Bakunahan 3. Next slide. We cannot stress enough the importance of vaccines to prevent severe illnesses. Based on our data on COVID-19 cases from our hospitals, 70.23% of individuals with severe and critical disease are not fully vaccinated or are just partially vaccinated against COVID-19. And 76.83% of COVID-19 deaths are among individuals who are not fully vaccinated. This shows that severe and critical symptoms are 1.48 times more likely to occur among non-fully vaccinated individuals, while deaths from COVID-19 is 2 times more likely to occur among non-fully vaccinated individuals as compared to individuals who are fully vaccinated against COVID-19. Having said this, the Department of Health continues to encourage our kababayans to get vaccinated. We reiterate that vaccines are safe and effective in reducing the risk of being hospitalized and dying from COVID-19. Next slide. As of February 20, 2022, around 33.5 million individuals are already qualified to receive their booster shots. Of this, only 9.7 million or 28.95% have gotten their boosters. Booster doses are shown to have significant impact in preventing hospitalizations and severe diseases. Vaccine effectiveness against hospitalizations for Omicron is 72% 2 to 24 weeks after the second dose, and this drops to 52% after 25 weeks. Vaccine effectiveness against hospitalization following a booster dose increased to 88%. The public is assured that all COVID-19 vaccines with an emergency use authority from our FDA are proven to be safe and effective against COVID-19. That's why we are inviting our eligible population or individuals to complete their primary series and get their booster shots to protect them not only just for the other variants, but especially for the Omicron variant. Next slide. So as our risk case classification and healthcare utilization continue to decline, it is inevitable that we need to readjust our strategies as we move toward against the pandemic. Let me share with you a few slides on what we could be expecting as we move forward to this new normal. Next slide. As we continue to adapt and plan towards the transition away from the idea of a pandemic, we first start with discussing what is meant by the term endemic. From an epidemiologic perspective, endemic means having a replication number at acceptable values and a shift from the view as a one-time threat in a prevailing problem, which should be addressed holistically. Basically, it means that society as a whole has identified an acceptable disease burden. We want to clarify current misconceptions about what it does not mean. Endemic does not mean that we do not have national government actions anymore. It does not mean that we remove all of our COVID-19 safeguards. And more importantly, it does not mean that the virus is safe or less virulent, or that there will be no disruptive waves or outbreaks. For example, endemic diseases include tuberculosis, dengue, measles here in our country, which continues to pose outbreaks and devastating effects to communities and healthcare systems in our country and even worldwide. Going through how the word is being used across global articles, what people usually think about the current use of the word endemic is a removal of pandemic restrictions. For example, national government will still communicate the preferred actions to the public for safety, but there will be no national restrictions such as lockdowns and limited use of mandates. Largely, it means a shift to self-regulation. It also means that safeguards become part of our routine life. For example, road accidents is another endemic problem here in the Philippines with a permanent impact to daily life, such as the use of seat belts. The safety measures necessary to reduce severe disease and death become routine and second nature to everybody. Lastly, we want to highlight Lastly, we want to highlight that these measures assume wide-scale access to technologies that limit the impact to disease, such as vaccination, boosters, and medicines. So groups who cannot access these remain to have high risk, especially the unvaccinated, the children, immunocompromised, healthcare workers who have to manage the healthcare system, and emerging areas or economies with inequitable access. Next slide. The road to easing restrictions toward a new normal has to be a balancing act. Theoretically, viruses tend to mutate to prefer transmissibility over virulence for evolutionary survival, meaning more infectiousness than causing more severe disease. And we saw this with the Delta variant being more transmissible than the original strain of the virus, and the Omicron more transmissible than the Delta variant. However, these new mutations can still be deadly, and there is no predestined evolutionary outcome that these viruses mutate to be more benign. For example, Delta was more deadly than the original strain. Individually, immunity, whether through vaccination or past infections, will theoretically have some protection over majority of the new variants. But variant mutation is unpredictable and will continue, especially in hosts who are immunocompromised and those populations who are not monitored. As an example, the Omicron variant was assumed by some experts to have come from immunocompromised hosts in South Africa, wherein vaccination was very low. For our community, we know that there is higher community knowledge, skills, and access to tools and actions which will be necessary for appropriate self-regulation. But this is dependent on equitable access, especially to the marginalized. This will also lead to greater complacency, which can promote increased transmission, further risking the vulnerable groups. Next slide. To provide adequate safeguards in the occasion that cases rise or our healthcare system is overwhelmed, we have implemented the alert level system that allows us to limit factors that may contribute to the situation of the pandemic. The different alert levels are based on the metrics of case increase or decrease alongside the utilization of healthcare system. These measures help the Department of Health provide appropriate actions to ensure the safety of our stakeholders and the lives of many Filipinos. Next slide. The national framework for COVID-19 response remains to be the PDITR response, and we want to reiterate that the PDITR Plus strategy cuts across all settings. Next slide, please. Specifically for PREVENT, we further subdivide these protocols to engineering, administrative, PPE, and public health measures. The emphasis on prevention highlights our previous point, where we are able to control the transmission across the different settings. To ensure our safety, we should plan and strategize with our different health systems to minimize the effects of outbreaks, especially for the vulnerable population. We should always ensure the safety of the populations most at risk due to the effects of the pandemic. Our COVID-19 vaccination program continues to show protection against severe and critical disease, while it makes certain that our healthcare system does not get overwhelmed. As we protect ourselves and our families, we are able to preserve our livelihood. And as we protect our livelihood, we are able to provide for ourselves and our families. Next slide, please. To provide cumulative protection, we have different layers of interventions. At the individual level, protection is provided through COVID-19 vaccination, which protects against severe disease and death. Appropriate and well-fitted PPEs also include added barrier to infection. At the level of the workplace, we recommend appropriate alternative work arrangements, reinforcing the roles of safety and surveillance officers to ensure the application of the PDITR strategies in our workplaces. And in our households, we can also have the layer of protection by ensuring that people we are usually in contact with are vaccinated. Also, ensuring household disinfection and minimum public health standards implementation at home remains important strategies for reducing infection. And finally, at the level of the community, We must ensure that the most vulnerable and exposed are protected because they are the groups that also demand healthcare need to be admitted in our healthcare facilities. Next slide, please. With the ongoing transmission, the different environments and settings will also need to undergo change with what is necessary for us to live in the new normal. Next slide. We continue to reiterate that behaviors are key to ensuring their health. People need to eat well, exercise, manage stress, and avoid substance abuse to stay healthy. But it is not enough to know that a behavior is healthy to start practicing such behaviors. We also acknowledge that we cannot focus on individuals' knowledge alone, but on the circumstances surrounding them, their peers, their culture, the laws, services, and products surrounding them that would prevent them from practicing healthy behaviors. Next slide. The 7 healthy habits are pillars to which efforts in improving health outcomes through health promotion will be centered on. These encompass some of the most pressing health concerns of young people. Through the 7 healthy habits, all individuals, communities, institutions, and structures are enabled to share responsibility towards creating healthy models and lifestyles. By addressing these 7, we hope to make the biggest impact in terms of promoting healthy behavior and influencing health outcomes. We want to encourage individuals to move more and eat right, be clean and live sustainably, get vaccinated, do not smoke, lessen alcohol and say no to drugs, care for themselves and care for others, practice safe sex, and do no harm, put safety first. But to do this, we want to ensure that their surroundings are conducive to health. Next slide. The healthy settings approach is an important strategy in ensuring the uptake of healthy behaviors. It offers opportunities to mainstream health and keep in top of mind by reaching Filipinos in the settings of their everyday lives, at home, at school, and at work. It also offers opportunities to address the social determinants of health by involving various stakeholders. With this, we naturally have to work with local governments, employers, regulators, school principals, teachers, and other staff, and other stakeholders to ensure that settings are healthy and health promoting. The DOH is working on frameworks for healthy communities and healthy schools, keeping in mind the importance of time spent at school and at home, especially by our younger people. Next slide. So in order for us to have a healthy community, our standards of how we run our community need to be revamped in order for appropriate changes we want to see. Can we have the next slide, please? We recommend the following changes be affected in our communities. Ensure improved access to safe and nutritious food with clean, potable water, opening up of public spaces and varying infrastructures for physical activity, making sure that our environments would have hand washing stations and proper waste management systems, warranting that housing conditions are made affordable, accessible, and livable, providing for smoke-free, vape-free, and drug-free environments, ensuring that people earn a reasonable wage in an environment that also takes in consideration their physical and mental health, making neighborhoods safe from violence and neighborhoods that are inclusive and harmonious across all ages, gender, and social status, and strengthening local health systems to be more responsive. Next slide. Besides capacity changes to our community, our healthcare facilities and systems will undergo modifications with adjusting to COVID-19. From a pandemic phase which requires COVID-19 dedicated beds in all hospitals, we are looking into that shift wherein only selected hospitals will be required to dedicate beds for COVID. We are looking at an endemic phase wherein dedicated COVID beds are no longer required. And we treat COVID just like a seasonal flu or measles and any other infectious disease whose infected patients shall be admitted at any healthcare facilities following infection prevention and control measures. Next slide. During the pandemic phase, we started requiring COVID-19 beds in all hospitals. Eventually, we are looking at no longer requiring dedicated hospital beds in the endemic phase. The ICU, ward, and isolation beds are no longer dedicated for COVID-19 patients specifically, but rather for infectious disease patients in general, just like measles and seasonal flu. COVID will have to be treated just like any other infectious disease, following the fundamental principles of infection prevention and control. Only designated infectious wards will there be a need to use level 4 PPEs. In the pandemic, we advocated for human resources for health emergency hiring for all hospitals. Eventually, human resource augmentation will only be in areas of outbreaks with low human resource for health capacity, and assignment of healthcare workers to infectious diseases will be based on demand for each respective facility. Instead of dedicated beds for the COVID-19 emergency department, we will institutionalize the infectious and non-infectious sections of our emergency rooms, and we recommend level 4 PPEs only in infectious areas. Next slide. So specifically for the health sector, the concept of pandemic proofing the health system is more than just an outbreak response. It will entail overall health system strengthening to meet health systems objectives, consistent with our universal healthcare directions. This means that for improving health outcomes, we need to ensure evidence-based standards development and regulation, primary care-oriented service delivery across healthcare provider networks, availability of innovative technologies, and clarification of the accountabilities in a devolved setup, especially for the national government, the local government, and our households. To be responsive to the needs, it means adequate access to healthcare facilities across the different levels of care, healthcare workforce development, including capacity building, and better mechanisms to retain our talents in the country, leveling up of our surveillance systems, and ensuring healthy settings in schools, establishments, workplaces, and communities. And accessing care, surveillance, performance monitoring also has to undergo digital transformation. And for protection from financial risk, this means reducing our out-of-pocket care, medicines and commodities, hospitalizations, and navigating the healthcare provider network. The new normal refers to emerging behavior, situations, and minimum public health standards that will be institutionalized in routine practices and will remain after the pandemic until the total eradication of COVID-19. Normal life is when infection prevention standards are permanently incorporated into our basic standards for safe and healthy communities, workplaces, and schools aligned with the Philippine Development Plan. So next slide. So our call to action. So this will be my last slide. Taking into all of these lessons together, the government continues to develop guidelines that are cross-cutting, data-driven, and inclusive. This is our call to action. Towards achieving a new normal, vaccination, safety seals, and promotion of outdoor and built environments are key. The goal of our vaccination is to protect everyone, most especially the vulnerable. And in achieving this, we should encourage all eligible to get vaccinated. The Department of Health is continuously working on its policies and in partnership with the DILG, assist local governments in their rollout. Safety seals are the assurance that PDITR and minimum public health standards are adhered and are in place. The more establishments provided with a safety seal, the more confident we are to say that these places are safe for the community. The Department of Health is working on integrating the safety seal into our routine health and safety. And in doing this, we continue to encourage everyone or establishments investing in ventilation and ensure the availability of hand washing stations. Modify physical environment to employ mechanisms allowing for physical distancing and other minimum public health standards, and ensure that there is access to health care among students, workers, communities, and promote the availability of our vaccines. Towards long-term sustainability of our gains, major investments such as outdoor and built environments have proven to be beneficial in reducing the transmission of the virus. The Department of Health cascades this through health promotion, as local governments are encouraged to invest in the same. As we transition into the new normal, we continue to remind everybody of the importance of the minimum public health standards and vaccination. Thank you very much and good morning to all of you.
Thank you, Yusek Vergele. We see you every day on television. I feel that you have more exposure than some of the presidential candidates these days. If you'd allow us, I just want you to clarify, because I think, as you said, there are some misunderstanding about endemic, right? That I just, want to hear you say again, endemic doesn't mean the end of the pandemic, right? It's just that the virus can still mutate. People still need to take precautions. We still have to be concerned, right? Is that correct? I don't want to put words in your mouth, but
Yes, sir. I'd just like to clarify. You're correct. When we say that it is the endemic state, we are not saying that everything is lost and we are stopping already because there
Right.
are no threats anymore.
Right.
I think the major misconception would be, first, the definition of what endemic is, and
Right.
second, that we are not still on that endemic state yet. We
Right.
are now in transition towards getting into that endemic state. But
Right.
for now, because we are seeing that cases are declining, we have seen that the cases are of milder characteristics compared to the Delta variant, but it does not mean that we are on that in that endemic state already.
Right.
It does not mean that there would be no variants anymore that will come in the future. That's
Right.
why even though we are now transitioning our strategies and intervention towards having this new normal, we still have these safeguards in place, and
Right.
we still have this alert level system which will signal to us if in case and if and when there would be increase in cases again, we are prepared to manage that and be able to all at once impose our restrictions again.
Right. I think people are just assuming that, because Omicron cases are down, they think it's okay, but they still have to be careful. It's good for you to clarify that. Yusek, when can we see the vaccines available to the private doctors? For instance, there are some people, if they get tested, their physicians will tell them you may need, an additional booster. When is that going to be publicly available? When do you think that might happen?
Yes, sir. No, so we have regulatory processes for us to be able to make available this kind of technologies in the market, private, public.
Right.
What we have right now for the vaccines, they are all under emergency use authority.
I see.
These vaccines have not completed the completed phases of these clinical trials that we have for these technologies. Usually you have 4 phases in a clinical trial, and these vaccines have only undergone until the 3rd phase of the trial. The 4th phase is the post-marketing surveillance, where you actually monitor the effect of these vaccines across the population that you are giving these to. So having said that, until the time that we can have the completed authorization from the FDA, and that is what we call the Certificate of Product Registration, wherein these technologies like the vaccines have already completed all of these requirements like the clinical trials, they can be given CPR, and once a vaccine has CPR already, it can be made available to the private or to the market
The
without
general
having
population,
to pass through the national government. Yes, sir. So we
Right.
wait for that all over the world. I think in the United States, they already have been able to get CPR for their vaccines.
For some
But
brands.
for the other countries, yes, EUA pa lang po talaga hanggang sa ngayon.
I see. We also heard from the news, and I was wondering if you can corroborate this. We saw that vaccine hesitancy is also declining. I was just wondering if you're seeing the same numbers, and also, of course, that refers to COVID-19. But we wrote last year also that the vaccine issue has also affected the regular vaccines that children usually take. I was wondering if you can comment on that, if the decline in the vaccine hesitancy for COVID-19 is also the same numbers you're seeing for the vaccines, for measles and other things that children usually have to get, when they're young.
Yes, sir. No. So actually, I think we're talking of 2 different things here. Not really
Right.
a difference in terms of hesitancy.
Right.
What we are seeing right now would be based on the latest survey that we have nationally. Vaccine hesitancy had tremendously, have declined. We only have about 8% of our population who are still hesitant, or are really not going to get the vaccines based on that survey. And that is a tremendous improvement comparing from the very first time that we've started, wherein vaccine hesitancy was really high, until we had the June survey where it was improved a little. But right now, only 8% are hesitant to get vaccines. What we are seeing right now would be more of access challenges, and not really the hesitancy. We are seeing that there is really that access issue in terms of those far-flung areas, in terms of those senior citizens maybe, or those with comorbidities who cannot go out of their houses. That's why our strategy right now for our Bayanihan Bakunahan is to really go out and map out all of these areas wherein people cannot go out because of their age, because of comorbidity. Comparing now with our usual vaccines, our vaccines for our national immunization program, everybody knows that the hesitancy increased during that controversy with another vaccine, and our immunization coverage really plummeted during that time because of this hesitancy. But in 2019, we started gaining ground again, and the immunization coverage started hitting those targets again for the whole country. Unfortunately, pandemic came in. No, so COVID-19 came in, and this has affected again our coverage for the existing immunization program vaccines that we have for our children. So as I've said, it's kind of different when we talk about the hesitancy part of those for the existing vaccines that we have for children, and the hesitancy part on COVID-19 vaccines, because the hesitancy for COVID-19 would be different from the hesitancy from the existing vaccines that we have.
Yeah, thank you. Thank you for that, Yusek. Red, I think, has a couple of questions. A reporter covering you most of the time. Red, go ahead.
Yes, good morning po, Yusek. Of course, we saw the figures right now that we are now inching close. We are now in low risk category. So I'd just like to integrate these questions. First, Yusek, do we need to talk together with other medical associations such as the PMA and the PCP in formulating the so-called new normal plan, or the new normal framework with the government? And now that we are now approaching the low numbers right now, should we be? Is it safe to say po ba na are we now out of the woods, or should we say na we should remain very much alertive, para we should remain alert pa rin po ba sa pandemic natin ngayon?
Yes, thank you, Red, for those questions. First, we are already drafting the National Action Plan number 5. And this is our new normal plan. And this is being drafted by concerned agencies of government, headed by the National Economic and Development Authority, NEDA, and of course, DOH is there. Now, with this plan, we are incorporating all of these transitional interventions and strategies, wherein we will be including still the minimum public health standards and, of course, vaccination. Now, with regard to consulting the different medical societies, that is part of our process. But we are just initially drafting it so that we can have a final draft to be presented to our stakeholders and our experts to gain additional recommendations from them. Although while we develop this and while we input to the National Action Plan, DOH is in constant coordination and getting inputs from our technical advisory group of experts. The second question would be that if we are out of the woods. So I like to request that we don't use that word, no? So people might really be so complacent if we say we're out of the woods. What we can say right now would be, first, I think, and we believe from DOH, that we are over the challenge from Omicron. Although still, from the whole genome sequencing that we are getting, it's still very much Omicron predominance of Omicron in our sequences. Yun pa rin, marami pa rin Omicron. Delta is slowing to showing na paliit na siya ng paliit and Omicron na talaga yung nagiging predominant. Pero nakita natin, milder ang Omicron than Delta. Nakita rin natin how fast the increase in the number of cases and how fast we were able to bring it down. In about a month's time, bumaba ang kaso. And that's why people, I think, became so confident. They got confident because of their past infection and because of their vaccination. And rightfully, we should give confidence to that. Pero this is not the right time and this is not the time for us to be complacent. Anytime a variant again might be introduced and get, or enter into our country or the other countries. And we know that, for viruses, borders, wala yan. It will always cross borders. That's why we have a pandemic right now. So our advice to people would be, in no time, or maybe in the coming months, may lalabas na variant dyan. Ang question, mas severe ba yan? Ang characteristic ba niya ay mas lesser ba yan for severity? Mas transmissible ba yan or lesser ang transmissibility? That's the question. Pero yung probability that a variant might again be introduced is very high because variants comes from mutations which are being cooked, dun sa mga taong immunocompromised, dun sa mga taong hindi bakunado. And we know that ang dami pa ring tao sa buong mundo na hindi bakunado. Ang daming immunocompromised. So the probability that this virus will continue to mutate is still there. Pero ang ginagawa natin dun sa ating plano to transition would be, there would be safeguards for us para naman hindi completely lost na wala na po tayong protection kapag sakali na may pumasok na naman na ibang variants.
And for my last question na lang po, Yusek, just a little message na lang po sa mga tao na very much so na hindi pa rin po confident magpabakuna. Any message na lang po to assuage people that the vaccines are safe and effective?
Yes, so we'd like to encourage everybody. Ang Department of Health po, ini-encourage natin lahat ang ating mga kapwa Pilipino na sana po magpabakuna na po tayo. The vaccines are safe and effective. This went through a very tedious process of evaluation, not just from the Food and Drug Administration, but from our vaccine experts. And if you look at the other countries implementing vaccinations, makikita po natin na lahat po ng bansa sa buong mundo ay naniniwala na safe po ang ating mga bakuna at saka effective po siya. Yung kanyang efficacy against severe disease and against dying has been proven even here in our country already. Nakita po natin, ikukumpara natin to before, yun pong number ng severe infections natin, number ng mga namamatay, lumiliit because mas madami na pong bakunado ngayon sa ating bansa. Bigyan po natin ng kumpiyansa yung ating mga bakuna. This is our way out of this pandemic together with our minimum public health standards. Another thing na gusto ko lang banggitin, please get your booster doses when you are already eligible to get it. Ang booster po, nakita po sa pag-aaral, nag-wane po ang immunity ng ating mga bakuna. Pagdating po dun sa time na mababa na yung ating immunity from these vaccines, from your primary series, bumababa hanggang 55% na lang ang protection mo against severe disease and death. Pero kapag ikaw ay naka-receive ng boosters, tumataas siya uli to 88%. So please get your boosters. We need this so that we can be protected, not just ourselves, but for our loved ones and our whole community. So thank you very much po for inviting.
Yusek, baka gusto nyong bigyan ng reminder yung mga nagkakampanya ngayon because we see from the news tens and thousands of people sometimes in an event, lots of handshaking, some people not wearing masks. Baka gusto nyong magbigay ng message to our people who are either participating in rallies or campaigning this season.
Yes, sir. So nakikiusap din tayo. We are giving this advice. Hindi lamang po sa ating mga kababayan na pumupunta po sa mga campaign sorties. pero most especially dun po sa ating mga kumakandidato at sa ating mga local governments. We know our safety protocols. Alam po natin, hindi pa ho nawawala ang virus. Nandito pa rin po siya. Sana po maisip po natin at maipatupad natin ang maayos ang safety protocols. Let us be leaders and models para po sa ating kababayan. Ipakita po natin sa kanila kung ano pong leadership ang meron tayo by showing them na kaya nating mag-comply sa mga protocols for safety para po alam nila na pinoproteksyonan nyo rin sila dahil alam nila na ipinapatupad nyo po ang mga safety protocol sa ating bansa. Sa atin naman po mga kababayan, iwas muna po tayo sa mga ganitong malakihang pagdadalo or mga events. Maaari po kayong ma-infection dyan, and if you cannot really avoid going there, please wear your mask all the time. Practice physical distancing as much as possible and ensure na pag pumunta kayo dun sa mga sorties po para sa kampanya, there is adequate ventilation dun po sa mga lugar na pupuntahan.
Well, thank you very much for those very timely reminders, Yusek Vergere. We have tons of questions still to ask, pero I know you have to go back to the front lines. We really appreciate your time, Yusek, and perhaps when there's another opportunity, we'd like to have you back. Maraming salamat po.
Thank you. Thank you very much po to all of you.
Thank you po ulit, Yusek. Thank you.
So for those who are asking if they can get a copy of the presentations today, please give us your email address in the chat box and we will endeavor to send you those. For the next speaker, I will turn over the screen again to my colleague, Red Mendoza, to introduce her. Red, the screen is yours.
Yes, thank you very much, Sir Clink. Now for our third speaker right now, of course, our third speaker is one of the top executives of the Philippine Health Insurance Corporation, or PhilHealth. Of course, Dr. Shirley Domingo, or also known as Doc Gigi Domingo, holds the position as Vice President of the Corporate Affairs Group of PhilHealth. And as the head of the group, she manages the communication, marketing, international and local engagement, Social Health Insurance Academy, and the Action Center of the corporation. Concurrently, she is also the official spokesperson of the 6,700-strong State Health Insurance Corporation, where she acts the face and the voice of the corporation and the beacon of inspiration. For Doc Gigi, being PhilHealth spokesperson is truly a challenging job for her, but she sincerely believes that her positive outlook in life, her many years in dedicated public service, and her genuine concern for the success of the National Health Insurance Program are among those that motivate her to do the job. Doc Gigi, as she is fondly called, earned her Doctor of Medicine degree from the University of the East Ramon Magsaysay Memorial Medical Center in the Philippines, and took up her master's degree in public health at the University of the Philippines. Aside from being a doctor by profession, Doc Gigi also earned a diploma in human resource development at the Ateneo de Manila University in 1996. Before joining PhilHealth, Doc Gigi served as director of the Health Human Resource Bureau of the Department of Health for several years. And as such, she managed the human resource planning, development, and management programs of the DOH. She likewise served as the head executive assistant to the late Secretary of Health, Dr. Alberto Romualdez, from 1998 to 2000. Without further ado, ladies and gentlemen, may I introduce to you Dr. Shirley Gigi Domingo, the official spokesperson of PhilHealth.
Thank you, Red, and thank you for inviting me here. I just have one thing to ask first. I sent you my presentation. However, I think I sent you the old version. So can I just share my own slides? Is that possible?
Yes, go ahead po.
Oh, sige. So hindi pa kayo nag-share. I'll share mine now. Wait, sandali ha. Nag-share na ako, but
It's coming up na, Doc.
okay.
Yeah, we see your screen now.
Okay. Can you see this now?
We still see your folders.
Yeah. Siguro it's just loading.
Yeah.
Sorry for this. Eto na, this is what's in my screen. Ito na yung screen ko. Folder pa rin ang nakikita ko. Ang nakikita niyo?
Yeah, yes, Dr. G.
Kasi in my screen is already my slides. I'm really sorry for this kasi I sent the wrong. Okay, wait. Can you see my slides now? O folder pa rin?
Folder pa rin. Dr. G, there's a Peter Perfecto saying maybe
I sent you just now, a few minutes ago, yung my new slides. Can you check it na lang?
Can our staff check if they received the new slides and maybe we can show it from our
Maybe
end?
around
We got it, sir. We got it, sir.
Okay.
We're ready.
Okay, so kayo na lang mag-share?
Yeah, we'll share.
Yes, ma'am.
Dr.
Okay,
G.
thank you. Thank you. Sorry for this.
No problems.
Ma'am, pa-end na lang po yung sharing. Thank you.
Okay,
Okay, Shello, I think you can share them.
okay.
There you go.
Okay. So can you see the slides now?
Yes, we can. Go ahead.
Okay, thank you. Thank you very much, and sorry for that technical glitch. I sent the wrong files to you last night. But anyway, let me start. Known as the gift of love to the Filipino people, the National Health Insurance Program was created through the signing into law of RA 7875 as amended in February 14, 1995. The law ensured universal health coverage to all Filipinos and ensured affordable, acceptable, available, and accessible healthcare services for all citizens of the Philippines. The law created the Philippine Health Insurance Corporation to administer the National Health Insurance Program. In February 2018, a landmark legislation, RA 112223, or the Universal Healthcare Act, was signed into law. The law ensured the achievement of universal healthcare in the country through an integrated health system or the healthcare provider networks that incorporates primary care into the continuum of services from preventive, curative, rehabilitative, and palliative care. The law further strengthened the rights of every Filipino to access quality health care at optimal and affordable cost by defining the roles of each player in the health field, integrating financial resources under a single payer scheme, and incorporating quality provisions through formation of a health council. The Universal Healthcare Act provides the country with a blueprint to ensure achievement of a healthy people and a healthy nation. The journey is rough and tortuous, full of challenges and small successes, but PhilHealth moves on, defying the odds and unfazed by these challenges. So, before that, please, the slide before that. Okay, so this morning, let me discuss with you some of the features of the Universal Healthcare Law, PhilHealth's mandates under the Universal Healthcare, PhilHealth's benefits, and our COVID response. And I hope to finish within my given time period of 15 minutes. Yes, please. Next, please. The World Health Organization defines universal health coverage as ensuring that all people have access to needed health services, including prevention, promotion, treatment, rehabilitation, and palliation of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. And I think the keywords here is highlighted. There is access, whether physical access, financial access, and quality services, and without becoming poor once you access health services. Next, please. Major strategies has been defined in this law. One is the provision of Filipinos to all Filipinos quality, preventive, curative, and palliative services, and focusing on primary health care. Second is promoting an integrated approach to healthcare delivery through healthcare provider networks at the provincial and the city levels, and also the formation of primary care provider networks. Third is institutionalizing mechanisms to ensure financial risk protection by controlling cost and promoting predictability of payments. In other words, every Filipino should be protected such that once they avail of health services, they will not be impoverished. So yun ang financial protection. Next. So where is PhilHealth in all this? PhilHealth's role is in the terms of population coverage. There is automatic inclusion of every Filipino citizen into the National Health Insurance Program. Automatic na po yun. In other words, they don't have, everybody is already a member. However, we request people, if they are not yet registered, to register so that you will be in our database. But you are already automatically a member. As to service coverage, there is a provision that says there is immediate eligibility. In other words, before this law, PhilHealth required payment of 6 months premiums before they can avail, 6 out of 12 or 3 out of 6, depending on what benefits. But right now, you can avail at once because of the immediate eligibility provision. However, we also will be requiring, or at least will collecting premiums, because without premiums, we cannot continue with our benefits. So aside from immediate eligibility, immediate eligibility and access to comprehensive outpatient and inpatient benefits. So hindi lang ho ito pang hospitals. There's a misconception that PhilHealth is only about inpatient benefits. No, we also have outpatient benefits, and we'll be discussing this later on. Also, the provision of primary care benefit package. As to financial coverage, there will be zero co-payment depending on the type of accommodation in the hospital. This is in the law. And fixed, predictable co-payments for those who can pay. Next, please. The membership of into PhilHealth now, when before we had around 5 types of membership, now it was only limited to 2. This is the direct paying members and indirect members. The direct paying members pays out of their own pocket, while the indirect, these are the senior citizens, the indigent, PWDs. The national government pays for their premiums through subsidy to PhilHealth. So PhilHealth receives subsidy from national government for the premiums. Next, please, of indirect members. As to service delivery, there is the population-based and the individual-based health services. Population-based health services is handled by the Department of Health. This is includes health promotion programs and campaigns, epidemiologic surveillance systems, and other functions of the Department of Health, while the individual-based health services includes inpatient and outpatient benefits, and also includes performance-driven, close and prospective payments based on DRGs to our providers. Next, please. So what is universal health care for a PhilHealth member? This is by no means exhaustive of the benefits of a PhilHealth member, but it will show you what you can expect as a PhilHealth member under a universal health care situation. One, as I mentioned earlier, everyone is automatically a member with immediate eligibility to outpatient, inpatient, and primary care services. The second, and this one will be very interesting, and we're working towards this, is that everyone is assigned to a primary care provider. So this is not yet, as I said, we're still working towards this, and I will be explaining this later on through the consulta. But everyone should be assigned to a primary care provider, and this primary care provider will serve as the navigator through the whole health system for that member. Third, PhilHealth will contract with healthcare provider networks in behalf of its members for benefit availment and hopefully to bring down the cost of healthcare. And another feature for the PhilHealth member is healthcare spending will be predictable because of the no co-payments or fixed co-payment provisions of this law. Next, please. So what is universal health care for a healthcare provider? We talk about primary care networks with patient records available throughout the health system. So wherever the member avails of their benefits, wherever in the health system, their records should be available and should be seen. So again, that's we're working towards that universal healthcare. But may I clarify that this is not only a PhilHealth mandate, but it's a mandate of the whole health system, the Department of Health and providers and other players in this health system. Differential payment schemes to give due consideration to service quality, efficiency, and equity. As I mentioned also earlier, integrated province and citywide healthcare provider networks and performance-driven, close-ended prospective payment schemes such as global budget based on the diagnosis-related groups. So we're moving also, we're starting the groundwork towards this type of performance payment, provider payment, that's global budget. Next, please. Okay, can you just press everything, please? Okay, this is just to show you in one slide the different building blocks that's in the law, in the Universal Healthcare Law, so that we can achieve universal healthcare. Universal healthcare is based on the principles of equity, quality, and affordability. And as I said, most of this that you see in the screen, all of this in the screen has provisions there in that law. But again, this is no means exhaustive of everything in that law. The law is really very comprehensive, and it's a good law. It's just challenging to implement each and every provision of that law. As to equity, there's allocation of bed capacities for no co-payment scheme. For GIDA areas, there are grants for networks, especially in GIDA areas. PhilHealth to grant incentives to bring services to GIDA areas. Preferential licensing for underserved areas. As to quality, there's third-party accreditation, health technology assessment, contracting, licensing and regulatory systems, and CPGs for clinical care. So this is the first time that CPGs was really introduced inside a law. It was mentioned that there is a provision for CPGs in the law. We have been discussing CPGs with the societies in the past. Societies are still doing this, medical societies, but this is the first time that it is in the law. Okay. As to affordability, there are provisions there that mentions co-payment, benefit rationalization, and complementation between DOH, PhilHealth, private health insurance, and the HMOs. As to affordable drugs and medicines, there's the National Price Reference Index, availability of generics, fixed markups, transparent pricing and price monitoring, and independent price negotiation board. I said this is nowhere exhaustive of all the provisions of the law. I just want to show you that there are a lot of building blocks needed to achieve universal health care. It cannot be achieved overnight, but once achieved, it would be very good for our country. Next, please. Okay, so you'll ask, what are the sources for funding of this universal health care? There are national government subsidies sourced from sin tax collections. Of course, the Department of Health also has their own appropriations. I would like to debunk the misconception that universal health care is PhilHealth. It's not. It's all about everyone in the health system, the local government units who owns the local health stations and local hospitals. It's the hospitals, the private sector, and the government hospitals. Everybody plays a role in universal health care. And this is funded through different ways. The local governments has their own subsidies from or allocations from taxes. So this one that you see in the screen is for PhilHealth alone. So we receive national government subsidy sourced from sin taxes. Part of the law also says that 50% of the national government share from PAGCOR goes to benefits in PhilHealth. 40% of the charity fund, net of documentary stamp tax payments and mandatory contributions of PCSO, shall go to PhilHealth. Premium contributions of members, annual appropriations of the Department of Health, and some supplemental funding if necessary. Next, please. Okay. With all that, with everything that I mentioned regarding universal health care and PhilHealth's role in that universal health care, what you see now is what PhilHealth needs to do in order to achieve its mandate. And that's the different pillars that you see. The provider management, we have to manage provider payments and come out also with the policies to be able to partner with our providers in a fair manner, that both will be able to benefit from such partnership. Of course, the member engagement, local government unit engagement, because local government units plays a big part in universal healthcare because of the healthcare provider networks that will be under the local government officials. And therefore, engaging with local government units is a very important pillar of universal healthcare. Of course, the other stakeholder engagement. Within PhilHealth, we need to plan for benefit designs. When you design benefit, it's just not coming out with we just don't come out with this benefit. There are a lot of work needed to implement or to design a benefit. We have to determine with limited resources what is the best benefit to come out with. This will, of course, need some researches and studies, which is done by HTAC. Under the law, it will be HTAC. And we have to determine also the best way to implement the benefit, etc. So there are a lot of work going into benefit designing. One very important pillar, of course, is financial management. With the money entrusted to us by our members and national government, then a good financial management pillar should be in place to manage that fund given to us. Of course, organizational efficiency and information and communication, and all of this will be the foundation would be a good organization and culture building within PhilHealth and within the health system. Okay, next, please. So those are the challenges. All of that are the challenges faced by PhilHealth. So let's go now into some specifics of PhilHealth. No? One is the healthcare providers, institutions. We have different hospitals, level 1 to 2 and 3 hospitals and also infirmaries and dispensaries. We follow the Department of Health in their licensing classifications. So the total as of now is 1,915. I'm sorry, this is December 31, 2020. We were not able to put in the newest, but it will also be around that number. And then we have other healthcare institutions providing benefits, such as the animal bite treatment centers, ambulatory surgical clinics, community isolation units now under the pandemic, drug abuse treatment rehab centers, DOTS, TB package providers, freestanding dialysis clinics, family planning providers, testing laboratories, MCP or the maternity care package providers, and the outpatient HIV/AIDS treatment providers. 60% of our accredited hospitals are from the private sector. And a big portion is level 1. Only 6% of our total accredited hospitals are level 3 hospitals. So a big portion, it's 76%, is smaller hospitals, level 1 and infirmaries and dispensaries. So these are the smaller hospitals. Next, please. So let's go now to the benefit packages of PhilHealth. They are inpatient benefits, outpatient benefits, primary care, and expanded PCB benefits, catastrophic or Z benefits, and some special benefits. The primary care benefits or the expanded primary care benefit package was already changed to another, and this is Consulta, and I'll be briefly discussing this later on. This is called the Consulta. Catastrophic or Z benefits are those that require a big amount of money, such as cancers, breast cancers, prostate cancers, kidney transplants. Those are all catastrophic benefits. Sige, next please. There's a list that I will show you on this. But okay, let's go first the PhilHealth inpatient and outpatient benefits. There are more than 8,000 medical and surgical cases. We call it the all case rates. Example only is in your screen. It's the hemodialysis, which we pay 2,600 per session. We usually only do 90 sessions, but during the pandemic, for the past 2 years, we expanded this to 144 sessions. Because we know that with 90 sessions and 3 times a week, maybe around July or August, nauubusan na ng sessions ang mga nagda-dialysis, and they were really, they lobbied really for an increase in number of benefits, because mahirap nga naman if you do that regularly, the cost, yung pagod na lang, no? And then you have to worry about where to get the funds, and therefore, we expanded these to 144 sessions for the year. Pneumonia high risk is also an example, at 32,000. Anyway, we have a lot of all case rates. We have a lot of conditions under these inpatient benefits. And there's an app on this. It's called PhilHealth's ACR. You can see there's a description of the condition, or if you know the code, most wouldn't know the code, but you can just describe the condition there, and they will tell you, the app will tell you how much PhilHealth pays for that condition. You can download that app. Next, please. These are examples of the Z benefits. Cervical cancer, wherein we pay 175,000, or it's a range from 120 to 175,000 depending on the conditions. All of this can be seen in our website. Kidney transplantation, we pay 600,000, and ALL, or acute lymphocytic lymphoblastic leukemia, wherein we pay 500,000. Z benefits are not available in all hospitals because we contract with the hospitals wherein where these benefits are placed. For example, kidney transplantation is done in NKTI, so not all hospitals are accredited for these Z benefits. Again, we have a list in our website. Next, please. So these are other examples of our Z benefits. I already mentioned the ALL. There's breast cancer for 100,000 and prostate cancer 100,000. Coronary artery bypass graft 550,000. Tetralogy of Fallot. This is a condition of the newborn. So 320,000 down the line. Again, all of this is in our website. Next, please. What's important, can you put it back? What's important also is these children with developmental disabilities, hearing disabilities and visual disabilities. We also pay a bigger amount for this type of disabilities. Next, please. We also have outpatient benefits, and therefore, I would like our members to know that madalas tanungin ako kasi why only inpatient benefits? As we know, we have a lot of outpatient benefits as well. For example, outpatient HIV/AIDS treatment or the OHAT is 30,000. Hemodialysis, I already mentioned and discussed this earlier. So animal bite treatment package is 3,000. Next, please. The next slide will show you other outpatient benefits. Transfusion, radiotherapy, and linear therapy. This is for cancer. Malaria, HIV/AIDS, TB dots, surgical contraception, and animal bites. So these are examples of our outpatient benefits. Next, please. Okay, there is this outpatient benefit package as a provision in the Universal Healthcare Law, wherein it includes already outpatient drug benefits and emergency medical services in accordance with recommendations of the HTAC. So this is different from the outpatient benefit I mentioned earlier. This one is a package mandated under the Universal Healthcare Law that PhilHealth should implement. And this is actually what I said earlier when we had that PCB, the primary care package, and later slides, there's what we call the consulta, which is a primary care package, and we will move into this outpatient benefit package. So nag-start tayo with the consulta, primary care, and then we will plan. The difference is the primary care package is consultations with primary care physicians. The outpatient package, nawala sa screen. The outpatient package will include consultations with the medical specialists and emergency care services. That's the outpatient package. Nawala sa screen yung presentation. Can you show it, please? Okay. Sa outpatient package na tayo. Okay, this is consulta. Before. I think slide 20 na tayo. 20, okay, so that's the outpatient package. So as I was mentioned earlier, we were already implementing an outpatient package, but it included only primary care benefits before the passage of Universal Healthcare Law. But under Universal Healthcare Law, we have to develop this outpatient benefit package, which includes medical specialist consultations, emergency services, outpatient drug benefits, but all of this has to be recommended by HTAC. Next, please. Next. So this is the PhilHealth Consulta, streamlining and expansion of services and access to primary care benefit. That's the objective of implementing a consulta. Consulta is a primary care benefit package, which we are now implementing. We have some providers. Next, please. Next, please. We already have some providers. Next. However, providers is not enough to service the whole of the population yet. But we are already starting on this benefit package. Sige, please, can you put in everything in the slide? Sige, everything, please. Okay, beneficiaries are all Filipinos. When we started doing this before universal healthcare, it was selected the population. We started with the Department of Education, the teachers, and also to indigent, kasambahay, may selected population when we started doing the outpatient benefit package. But under the universal healthcare, it should be offered to all Filipinos, and therefore that's what we're doing now. Benefit package amount would be 500 per capita for public facilities and 750 for private facilities. It will be a capitation, performance-based payment mechanism. And inclusions of the benefit would be consultation with a primary care provider, targeted health risk screening and assessment, 12 diagnostic workups, and drugs and medicines. Next, please. Okay, next, please. Okay, let's go now to PhilHealth's COVID-19 response. Next, please. What were the benefits that PhilHealth implemented during this pandemic? It was really very challenging. No one expected a pandemic to come in that when we were ending 2019. No one expected a 2020 that will have a different health scenario, especially a pandemic. No one expected that. Therefore, it was really very challenging also for PhilHealth. Our organizational setup was not wired for a pandemic, wherein more claims came in. But we responded to these challenges. So anyway, we had benefits for testing earlier in the pandemic. Napakukonti ng testing centers, and they were not also equipped with requiring what we required in terms of claims payment. No, they had to, because at the time when this started, PhilHealth was already receiving claims through e-claims, but most of our testing centers were not equipped with such a facility, and therefore they had to submit to us manually, and that had a challenge for PhilHealth because we again had to encode all these claims coming in, when before this was already encoded. Now we had to encode it. So those were challenges in the testing benefit. But right now, we have a testing benefit for cartridge-based and plate-based RT-PCR. A lot of people is asking about antigen. We are developing that. In fact, it's developed already. It's just in the process of approval. So that's for the antigen. Very soon, we'll be coming out with that benefit. So testing benefits, if you'll see the stats later on, most of our COVID benefits are through the testing claims. Home isolation benefit, we give 5,917, but this is not yet really taking off. The benefit is there, but there are still not very much providers. In fact, we only have 6 providers that responded to this for various reasons. No? There's some LGUs that prefer community isolation units instead of home isolation for positive cases. There are a lot of issues yet that we're resolving for this home isolation. And the payment is for the provider, not going to the member. So again, there's a misconception there that the members will be paid this home isolation benefit. No, it will be the providers. But as I said, the challenge is really getting providers to come in for this benefit. Community isolation, we pay 22,449. So this is being availed of already by many community isolation units all over the country. Inpatient care, we pay from a range of 43,997 for mild pneumonia cases, up to 786,384 for critical cases of COVID inpatient. Now, the vaccine injury compensation, this is also part of another law for vaccine injury. Anyone with a proven vaccine injury that's life, it's just not the usual cough or headaches. It should be sorry, I forgot the term, but it's life-threatening or leads to permanent disability, then they can be compensated for vaccine injury. Okay, next please. Aside from what I already mentioned, we suspended during this pandemic the single period of confinement and the 45-day limit, benefit limit. What does this mean? In a year, a member can avail of the benefits, inpatient and outpatient benefits, for 45 days. That's the limit. However, this was suspended during this pandemic. And the single period of confinement means that within 90 days, if it's the same condition being for inpatient, then we'll pay only once. However, this was also suspended during this public health emergency. Next, please. So as you can see here, this is the claims, COVID-19 claims received by PhilHealth. 93% is test claims. And only 5% is inpatient and 2% is community isolation. However, that's as to number. As to amount, malaki syempre ang inpatient. Malaki rin ang testing, but hindi ganito kalaki ang differences because malaki ang binabayaran natin for inpatient COVID claims. Next, please. Oh, wait, before you go there. Can you put it back to the, yeah, okay. So for testing claims, we have already paid 3.05 billion pesos to date. For inpatient claims, 5.3 billion. And for community isolation, 375 million. This was as of September 10, 2021. Next, please. This slide just shows the increasing number of claims that comes into PhilHealth. So last year, last year in 2020, it's 11,407,000. In other words, we are receiving around 1 million claims a month. So ganon kalaki, and we're putting out, we're paying around 2.5 billion a week in benefit claims. For all benefits, not only COVID, for all benefits. Sige, next please. So as of August 24, benefit claims amount received was 170.2 billion, but this is August 24, 2021. And that's equal to around 20 million claims, number of claims. We have paid 132.6 billion, again, as of last year. And that's around 14.8 million number of claims. Next, please. This will show COVID and non-COVID payments in 2020 and 2021. 99% of claims in 2020 was still non-COVID, with the amount of 94.1 billion. COVID-19 last year, 2020 was 1% pa lang. So konti pa lang at that time. So, but we already paid around 2 billion. Included in this kasi at the start of the pandemic, without any knowledge yet of how much should we pay in case of case rate, we paid for 1 month, we paid for the whole amount of hospitalization. That was full financial protection. And then we moved into case rates because that was not sustainable. So in 2021, tumaas na yung COVID-19 cases, 17%, but we were still continuing receiving non-COVID, and that's 83%. So a total of 148 billion in September of last year. Next, please. Oh, just a little payabang naman ng konti. PhilHealth COVID-19 response was awarded with the Continuous Improvement Recognition Award by ASEAN Social Security Association. Again, next, please. So this is my last slide, and I want to leave you with some lessons learned from the pandemic and to apply in our new normal, which is still our guiding principles at the moment. we learned that government definitely cannot do it all alone in providing health services to the people. Public-private partnership is very important. As we saw during this, in our drive to immunize the whole population, malaki ang naitulong ng ating private component dito. They were immunizing their own employees and offering vaccinations also to others. So government cannot do it alone, especially in this pandemic setting. We have to strengthen connectivity within the health system. That was very important as seen during this pandemic. And it's good that we know that in our blueprint for this health system development, which is the universal healthcare, nandun na yon, yung connectivity na yon through that healthcare provider network. So I think the design of the health system through the universal health care law, it's very relevant. It's a good design blueprint. Very challenging though, but it's good. It's a good blueprint. There might be some tweaking necessary in the future, but overall, universal healthcare law is a good law. Accountability to self and to the community, like distancing, ethics. It really depends on each and every one. It is our accountability to the community to be able to do our share, like vaccinations, para maprotektahan the rest of the population. All of that is necessary. We definitely saw going back to healthy lifestyle was important and preventive care because we had to, dapat malakas ang ating immunity para hindi na magkalat ang COVID-19. We saw that in this pandemic, di ba? And what is that all about? That's healthy lifestyle, strengthening oneself para even if you are infected, it will not be a bad condition. It will not go into critical. So yun, we saw the importance of going back to healthy lifestyle and preventive care. And again, tama-tama, we're offering the Consulta, which is a preventive care package, a primary care package. Health and economy are bedfellows. We have seen that. I don't need to expound on that. And lastly, communicate and learn from it. So with that, I want to thank everybody for listening to me. And I want to thank Manila Times for inviting me to this forum. Thank you very much.
Thank you, Doc Gigi. At this point, maybe we can bring back Mr. Salva from AMOP for a brief Q&A session with Doc Gigi. I noticed also there was a hand raised among the attendees. If you can please type in your questions instead in the Q&A feature, and we will endeavor to ask as many as we can, but note that we are running out of time. Before I give the screen to Mr. Mendoza, I just want to ask both Mr. De Silva and Doc Gigi, maybe if you can talk about the financial condition of your organizations, because I noticed Mr. De Silva said they paid 3.68 billion this year, followed by 3.89 or more than half of the 3.89 claims paid last year. And of course, PhilHealth has also been doing hundreds and billions of payouts because of the pandemic. How are you weathering the storm? I mean, maybe talk about maybe what policy assist you may need as well. Mr. De Silva, go ahead.
Okay. One good thing that has come about from COVID-19 is it has proven to all and sundry the Filipino people that having an HMO product, a policy, a service is good for them. And therefore, especially for corporate accounts that are currently members of HMOs prior to the pandemic, saw to it that their policies persisted. admittedly, there were some delays in payments because, money was tight, difficulty in billing, difficulty in getting in touch with them face to face. Admittedly, there was some delays. Of course, there are grace periods in paying the product's membership fees. However, it has caught up. The corporate plan holders saw to it that they are able to pay the membership fees that are due and payable to the HMOs so that precisely the policies do not lapse. They do not lapse. So another thing is we have seen that no matter how difficult it may have been for some, those that have not closed shop sought to buy HMO products as well. So we saw a small uptick even in the height of COVID-19. Of course, it is now expected that as we weather the storm of COVID-19, more and more people have proven that it has helped them in the past, and therefore, we hope that they will see the value of an HMO product that they can use if and when they get sick.
Dr. G, how's PhilHealth? May pera pa ba?
Yes, may pera pa tayo. PhilHealth is liquid. We can pay benefits pa rin. We have a reserve of around 154 billion. Maybe bigger at the moment, no? But that's the latest amount that we're saying officially. We get a national subsidy for premium payments, no? Not for operations, it's for premium payments, and that keeps us afloat actually. But looking at collections, nakaka-collect pa rin kami. Collections are still good, and we're thankful for that. Of course, we suffered in some membership sectors like the OFWs, wherein we were mandated to stop muna collections doon by Malacanang. And we did not increase our premiums as mandated by the law. We're supposed to increase 0.5% every year until we reach 5%. However, we suspended this upon direction by Malacanang. In time we will have to follow the law and increase payments because we have paid a lot of introduced a lot of benefits, but we have not increased our premiums. But we're still liquid.
Do you think there will be an increase in premiums? Have you requested this? What is the process? Is there a new law required, or is that have to go through the PhilHealth board? And do you think that will happen this year or next year?
Well, it has to happen because it's already in the law. Actually,
Okay.
it is in the Universal Healthcare Law.
Oh, I see. Okay.
Yeah, if you look at the law,
yeah.
yes, if you look at the provisions of the law, may table talaga doon. And there's a specific year and the percentage increase. So it's in the law. So we should be following that law because we can also be liable for not following the law. But aside from that, we really need funds to introduce more benefits and to pay for the benefits.
Yeah.
So yeah.
There's a question here from one of our viewers, Ablan, and Mr. De Silva may want to answer this. I put him on mute for now. But regarding HMO coverages, will there be a time when COVID cases will be not covered by HMOs? I think the premise here is that pandemics are usually excluded from HMO coverages, but COVID-19 was the exception.
Well, let's put it this way. A DOH declared epidemic or a WH declared pandemic are traditionally exclusions in an HMO healthcare plan. However, because of humanitarian reasons, earlier I did say that we are now under an Insurance Commission regulatory environment. And early on into the pandemic, the Insurance Commission has put out a circular asking all insular healthcare regulated entities to be magnanimous in covering COVID-19. And the HMOs readily agreed to do that despite 7 legal perspectives that we need not cover. So we did. Now, do we continue covering it? COVID-19? Perhaps. Perhaps. We've come this far. Earlier, I said that all told, in the whole of 2020 and the first 9 months of 2021, we have already paid 5.8 billion in COVID-19 payouts. Now, that is expected to continue in October, November, December, which we will find out through another survey by January 15. It has been submitted already, and results of that survey are going to come out pretty soon. However, to date, as we speak, we still cover that. So the next survey months will be January, February, March, and so on and so forth, perhaps up to the end of the year. So this can really spiral more than 5, 6, 7 billion, maybe up to the end of the year. Assuming that we are done with COVID-19, perhaps the next pandemic, I hope it never happens again in our lifetime. It's hard to tell whether the HMOs are still going to cover a DOH declared epidemic or a WH declared pandemic. I don't have the answer to that. But coming from the experience of this pandemic, and there is a chance that through humanitarian reasons and ex gratia payments, perhaps if business is good, why not share it with the Filipino people? I hope I answered that question.
Thank you, Mr. De Silva. Thank you, Mr. De Silva. Red, would you like to ask some questions?
Yes, Sir Kling, thanks. First question, this one my only question to Mr. De Silva. Now that you said that more of your clients or HMO clients are corporate clients, but are we planning to expand the audience or expand the reach of HMOs to household? Because I've heard that some HMOs are selling their health insurance products on online marketplaces or even electronic money sellers. So how are we expanding the audience of or the reach of HMOs to reach households instead of course, corporate clients?
Okay, good question. For at least the past 10 years, the association got involved with governments, the DOF, governments' initiatives for micro health. As a matter of fact, the former commissioner, Manny Dook, was saying that he hoped that the HMOs would come up with micro HMO coverages. Now, micro health is supposed to be for the fishermen, the tricycle drivers, the farmers, the market vendors, etc., etc. However, to be frank about it, most HMOs in the land concentrate on corporate accounts, not even on individual accounts. Individual accounts, from an actual perspective, that's one-on-one, coming from an individual perspective. However, for corporate accounts, you have a bigger base, which means, going to the Bayanihan concept of the managed care, the healthier people subsidizes the not so healthy people and the sickly people. And therefore, under a corporate account, one corporate account for bigger BPO can be 40,000 heads. Can you imagine the spread that you're going to have coming from an actuarial perspective? So that's one reason. Second, in selling it to the client, you speak only to one person, maybe the HR head or the president. You speak to one. However, for micro health, you speak to the individual. If it is going to be the farmers, the market vendors, the tricycle drivers, that's one-on-one. But then again, just to answer your questions, yes, there is an HMO. There are some HMOs that concentrate on micro health coverages, which is really for the marginalized sector of society. We are having that. Now, to make it faster in selling, we have over-the-counter card types of coverages, okay? But all of these plans and products are approved by the Insurance Commission. That is a given. Anything that you sell to the market, in the marketplace, any HMO product is approved by the Insurance Commission. So there is safeguards there as to benefits packages, the reserves it requires, etc., etc.
Okay, thank you very much, Mr. De Silva, for answering that question. And my last question na po for Doc Gigi Domingo, PhilHealth. I know that PhilHealth has been in the news in the past few years dahil sa mga allegations of corruption, and of course, so many have been saying that PhilHealth should be managed not by someone who is appointed by the president, but should be of a professional financial management expert. Doc, your take on this, and also lastly, do you think PhilHealth is ready? Of course, we know the future of UHC is very much wide open, especially during the pandemic. So, do you think po ba ang role ng PhilHealth will still remain as important in the years to come, especially now that ano ang magiging main role ng PhilHealth when it comes to achieving the goals of the Universal Healthcare Program?
Yes, thank you for that, Red. I've been asked always that question as to the qualification of our president. In RA 11223, or the Universal Healthcare, there's a provision there that sets the qualification of the president. And let me read it. PhilHealth must be led by a Filipino citizen with at least 7 years of experience in the field of public health, management, finance, and health economics, or a combination of any of these expertise. I believe all the presidents that passed through PhilHealth were qualified to head PhilHealth, no, as the president of PhilHealth. We all know that in an organization, once you go up the ladder, become the highest, you need more general management experience because you have a lot of technical people there. But of course, a good knowledge of the technical operations of that organization is good to have in order to manage it. So I think every president that passed through here were qualified to handle PhilHealth. May I just point out another thing about organizations? The head of an organization should manage what's going on in that organization at that moment, no? And it's different for each organization. Alam natin lahat yon that medyo tumultuous yung organization ng PhilHealth, no? And each president had to handle this when they came in. Handling the work, the technical work of PhilHealth may be a lot easier than handling the organization itself, no? So what I'm saying is may rason that people, these presidents were put there and they were able to handle the situation. Unfortunately, in these past 7 years, no, not one president stayed long enough to be able to manage the necessary strategic plans that were put in place. No, the technical issues in PhilHealth needs long-term solutions. For example, yung IT, you cannot do that overnight. We need a very good IT, but you cannot do that overnight. And all presidents that passed here knew that and started the planning for that. However, they were not given the chance to implement all of this. So I'm saying, yes, we need somebody, we need a good manager of PhilHealth, no? But that manager should be able to manage not only the program, very important to manage the organization. And that's very challenging. And the other question was the importance of PhilHealth. in
Yes, po.
universal healthcare? Let's put it this way. PhilHealth is a prepayment scheme. In other words, without a prepayment scheme in place, only those with the money to be able to pay for hospitalization can go to a hospital. Pag ikaw wala kang pera, how can you avail of hospital services if there's no other scheme in place? So let me put it this way. I'm not going to say that PhilHealth is very important. What is important is the mechanism of a prepayment scheme, a strategic purchasing scheme in behalf of our members to bring down costs. Those are very important to be institutionalized in the Philippines. Whether it's a social health insurance scheme or any other schemes, it has to be put in place. Otherwise, if it's only out of pocket, payment out of pocket, then that's not equitable, because only those who have money to pay will be able to avail of health services. What about those sections that cannot pay, that do not have the money to pay? So the scheme is very important. Whether it's PhilHealth or not PhilHealth, the scheme has to be there. And that's part of universal healthcare. So there, thank you.
Thank you, Gigi. And there are more questions, but I think we have to end it here. We'll ask the speakers for a final comment. I see Mr. De Silva wants to say something also, but perhaps we can give you time to make a final comment and or give a final message. Since Mr. De Silva, you have your hand up, maybe we'll give it to you. You want to make your reaction and then your final comment, and I'll ask Dr. Gigi.
Sorry, but my reaction is going to be quite long. I'm just going to make a final statement. The HMO industry is glad to be an integral part of the healthcare delivery systems of the country. And we aim to continue to do that for many, many more years to come for the benefit of the Filipino people. Thank you.
Mr. De Silva, I think we have a lot of questions to ask also, but perhaps we can set up a separate roundtable interview with you. I'm particularly interested in discussing the VAT issue, but maybe on another occasion. Dr. Gigi, your final message, please.
I just want to say that PhilHealth is working doubly hard with all the challenges thrown our way. We're still here. We're handling these very challenging times, and we hope to be of service to the Filipino people. That's our final goal, really, to be of service to the Filipino people, to all of us, service all of us, and we hope that we will still be able to provide such benefits and fix up the organizations. Lots of challenges, but we're moving there. Thank you.
Thank you, everyone. Thank you, Red. And of course, thank you to all those watching this business forum today. We will write stories in tomorrow's newspaper about the discussions shared this morning. And of course, we will be uploading a video recording of this event on the Manila Times channels on YouTube and Daily Motion. Once again, thank you, everyone, and see you at our next event. Maraming salamat.
Thank you,
And
everyone. Bye.
I would like to thank also our partners as well, Consumer Protect, Medgate generally, and Okada Manila for the food. Thank you very much. Our sponsor, International SOS, and our organization partners, British Chamber of Commerce of the Philippines, French Chamber of Commerce, Davao Chamber of Commerce, Financial Executives Institute of the Philippines, Italian Chamber of Commerce of the Philippines, and the Management Association of the Philippines, and of course, our media partner, the Manila Times TV. Thank you very much po. Thank you, Sir Kling, for the opportunity. Thank you to our guests, and good afternoon to every one of us.
Thank you, everyone. Thank you.
Bago pa man magsimulang tumigil ang mundo ng dahil sa pandemya, napakadami na namin ginaharap para lang magampanan ang aming tungkulin. Matugunan ang pangangailangan ng nakararami. Simula sa lungkot na dala ng pagsampa, hanggang sa iba't ibang klaseng trabaho na dinaranas namin sa araw-araw. Kalakip ang pangako ng magandang bukas. Patuloy kaming babangon para matugunan ang inyong pangangailangan. Patuloy naming iaalay ang aming oras at kakayahan para mapanatili kayong nakangiti. Patuloy kaming maglalayag sa iba't ibang dako ng mundo upang mapanatiling maayos ang inyong kalagayan. Ilan lang kami sa libu-libong manggagawa sa karagatan na nagnanais ng karampatang pagtrato at respeto. Para sa aming napiling larangan, sana sa araw na ito nilaan para sa amin, maisip mo rin kami. Nagmamahal, marinong Pilipino.
Your doctor. She is a phone call away. Whenever, wherever you need her. If there's anything you need to know, she will be in touch. Anytime, day or night, even on holiday. She doesn't just have one solution, but the one you need. Medgate. Call Doc. Anywhere, anytime, no line.
This is our home. And we're doing our best to keep it safe and free from harmful elements. So how do we ensure that your next visit here will be truly safe and memorable? Simple. We went back to our roots to find out what makes Okada Manila special. Okada Manila is grounded on Magokoro, or a true heart that's dedicated to service. Fusing the finest of Filipino and Japanese hospitality, we have built a world-renowned destination. Now, our core principle is put to action as we adopt a comprehensive system designed to keep you safe and healthy. We call it 3T, which stands for True Clean, True Safe, True Heart. With True Clean, we use the leading edge in technology to sanitize critical areas, from UV robots to walk-through disinfection tunnels. We have even innovated in how well we sanitize the smallest spaces. With True Safe, you can be sure you are in good hands. Our people have undergone stringent training to adapt to the demands of the new normal, to think steps ahead, to respond to your needs before you realize it. While True Heart is the wellspring of these measures, it has allowed us to ensure that every act of service is done with commitment and grace, as well as inspiring us to develop innovations to further enhance safety, such as hygienic cashless transactions using Okada Pay. Indeed, every space in the property is enhanced with a gold standard in cleanliness and safety. The 3T system prioritizes your well-being, giving you unparalleled peace of mind. So that when we welcome you back, you'll find a sanctuary that is truly clean, where you'll feel truly safe, delighting you with service with a true heart. Always driven by our values, we know only of one thing: to give you a place that even in these challenging times, you can call your home.